Hello, hello, hello. We are back. And boy, are we going to jump right in. This is going to be our first chapter on a joint. So if we want to think about what we've done so far, we did some introductory chapters on kinematics, kinetics. Then we did some chapters on bones, muscles, joints, and then the neuromuscular connection. So we've been building all these important pieces. So now for the rest of the semester, we're just going to go joint by joint. We're going to start with the upper extremity. So here we are with the shoulder. And then we're going to move on with the elbow, wrist, and hand. And then we'll have an exam on that, on the upper extremity. And then we'll move through the lower extremity. These chapters do tend to get pretty anatomy heavy. So I'm really going to be relying on your knowledge of the anatomy, the bony structures, for example, ligaments, etc. So if you aren't as good with that, you're going to have to review, okay? But as always, I'm going to focus on what's most important. Okay, here we go. The shoulder. Okay, before we even get started, you can see if you're following along with your notes. Let me change color. I feel like, let's go with yellow. We're going to start this bright and cheery. When we talk about the shoulder, it's very complex, right? We really rely on the shoulder and the joints in and around it to provide us with a lot of mobility and allows us to do a lot of activities of daily living, but certainly for our discussions, activities involving sport, right? It's technically including 5 articulations or joints. I know we think of the glenohumeral joint, which is the actual shoulder, but there's many other joints in and around the shoulder that make it all work together. Overall, these structures, compared to the lower extremity, tend to be unstable. Think about it. You know, a shoulder dislocation is fairly common. If we compare that to the hip dislocations are very uncommon. It's an easy example to do. The shoulder, less stability, but more motion. So we sacrifice some stability to get more motion in the shoulder versus the hip, which is the opposite. We really need it to be stable and strong because the hip is supporting a lot more body weight. But in order for it to be stable and strong, we sacrifice that mobility. And then you can see other characteristics, large range of motion, but as a result, in order to get that mobility, it's less stable and much more prone to injury. All right, we're going to jump right in. And the first joint we're going to discuss is the actual shoulder joint, glenohumeral joint. You're going to see a similar outline for each joint. So if you're following along in the notes, at first we're going to review what 2 bone surfaces form that joint. Then we're going to talk about what type of joint it is, what movements are allowed. Then we'll talk about some ligaments, the muscles around it, and then characteristics of the joint. So here's our first one, glenohumeral joint. You know what's nice, folks? Smile. A lot of these joints are named for the bones they connect. So check it out. This is the joint between the glenoid cavity of the scapula and the head of the humerus. Glenohumeral, joint between the glenoid cavity of the scapula and the head of the humerus. You absolutely need to know these. Glenohumeral joint. This is what we think of as the shoulder, formed by the glenoid cavity of the scapula and the head of the humerus. Some points to make. This socket, so to speak, the glenoid, it is not very deep. Check out this picture, right? We got a big old head of the humerus fitting into a pretty shallow socket. So we have low stability. It's not a very deep socket, so we're not going to get much stability. But we sacrifice that stability to get more movement, more range of motion. What type of joint is this? Well, it's a synovial joint. Everyone should know what type of synovial joint. It's a ball and socket synovial joint. The ball is the head of the humerus. The socket is the glenoid cavity. Cool, cool, cool. Movements allowed. Everything. Let's see. Okay. What are the movements that are allowed? Flexion, extension. That's, of course, in the sagittal plane around the... which axis? Review. Abduction and adduction. Internal rotation, external rotation, circumduction, which means to put it all together and form a big old circle like a third base coach is rounding someone, a runner, to run home. And then I want to remind you, we can also do horizontal abduction and adduction. Make sure you know all of these. All right. Other characteristics, we can see number 4 on your notes. The glenohumeral joint movement, it's rarely linear. And all that means is it's pretty rare for an activity to involve only flexion without any internal external rotation or abduction or adduction. So usually we have a combination of movements together. So it's rarely linear in a straight line or just one motion. It's rarely just glenohumeral flexion. Most of our activities are multiplanar, and as a result, because most of our arm motions are multiplanar, they involve multiple motions at once. You might have flexion with some adduction. You might have extension with some internal rotation. Alrighty, look at number 5. Glenohumeral joint movement almost always involves some of the others. Now, why don't we just do a preview? I know you're really excited. Can you tell them a little extra? You know, I missed you last week. So when I come back, I'm even a little more extra than usual. So what are I mentioned, we have 5 articulations that together form the shoulder complex. That's what we're going to call it. The shoulder, let's just make sure we have a look at what we're talking about. The shoulder complex. Yes. 5 joints. Number 1 is the joint we're talking about right now, the glenohumeral joint. That's the actual shoulder. The next joint we're going to talk about is the scapulothoracic joint between the scapula and the thoracic cage. When I said that the glenohumeral joint rarely acts alone, these are the 2 joints that commonly work together. So pretty much always, any glenohumeral motion is also going to include some motion at the scapulothoracic joint. The other joints, and these are all in your notes that we're going to talk about starting today. The acromioclavicular joint. Then we have the corticoclavicular joint. And then we have the sternoclavicular joint. Oh, what fun we're going to have. I bet you can't wait. But let me just remind you, the glenohumeral joint almost always involves motions of other joints, most specifically the glenohumeral and the scapulothoracic. When one is moving, usually the other is moving also. I want to remind you about the angular motions versus the gliding or translation. This was actually a test question, folks, wasn't it? We can have a look at this x-ray before we talk about that. This is how it should look. We get a good look at how shallow, folks. Look at how shallow that glenoid cavity is. Conversely, look at how big this head of the humerus is. Pretty shallow socket. Okay, but while we're on this page, just because I have space that's blank on the edge, let's review the angular versus gliding. Angular motion, and then the gliding, but it's also called translation. So we're going to say the gliding or the translation motion. It was a test question, so this should be a review, but it does involve the shoulder, the glenohumeral joint, so we're going to talk about it. The angular motion is the larger motion you can see with your naked eye. The example I gave was abduction. If I abduct at my glenohumeral joint, I can see it with my naked eye. It's a larger motion. But what's happening on the inside is a gliding or translation movement. This is a very small motion, and it occurs microscopically. Perhaps not microscopically, but you can't see it with your naked eye. Can't see with eyes. Usually it involves some sort of gliding. And I'm not even going to give you the example in detail again because you already know it. The example we gave was with shoulder abduction, glenohumeral abduction. We can abduct alone about 90 or 100 degrees. But once we continue to abduct, and if we could look at this picture, right? Wouldn't abduction be moving this arm up to the side? But once the arm gets to like 90 degrees or so, it will actually bump up against the acromion process. So we can do the first 90 to 100 degrees of shoulder abduction on our own. But in order to clear the acromion, what has to happen? The head of the humerus, on a very small scale, the head of the humerus slides down. It glides down. So that gliding down, slight glide, allows the head of the humerus to clear the acromion, and we can get additional shoulder abduction. Should be a review. I'm just telling you again. All right, so we know the basics of the glenohumeral joint bones. Let's talk about some ligaments. There is a collection of ligaments around the glenohumeral joint, conveniently called the glenohumeral joint ligaments. They're the glenohumeral ligaments. Let's see. Look, glenohumeral ligaments. So it's not like the knee where we have the MCL and the ACL and very specific names. Here we just have a collection of ligaments. We may remind ourselves that ligaments connect bone to bone. They're going to be on the outside of the joint capsule, and they give stability. If we look at the glenohumeral ligaments, do I have an up-close look? I do not. The glenohumeral ligaments actually kind of form a Z. That's what, I don't know. I'm not sure how, you can't really tell from this picture. But sometimes they're said to kind of form a Z. There are different bands. So there's a superior band, a middle band, and an inferior band, but they kind of all blend together. So here's what I want you to know about the glenohumeral ligaments. They're collectively known as the glenohumeral ligaments. They blend in with the joint capsule. Even though they're on the outside of the joint capsule, they kind of blend in with it. Again, this is different from like the ACL in the knee, the anterior cruciate ligament. As we're going to find later, that's like a rope-like structure that's kind of separate. It's not part of the joint capsule. But these glenohumeral ligaments, they pretty much provide a thickening of the joint capsule. Okay. When we talk about, actually, I'm gonna put a pin in that and shelve it for a minute. Okay. We also have another ligament, and you can see on your notes here, the coracoacromial ligament. That goes between the coracoid process and the humerus. We really don't get a good look here. I'm not going to ask you about that. If it was to be drawn in here, the coracohumeral would kind of be like this, because it goes between, this is the coracoid process, and this is the head of the humerus, right? So the coracohumeral ligament goes between the coracoid process and the humerus. But I'm not going to ask you about that. I just want you to know the group of ligaments that surround the glenohumeral joint, collectively known as the glenohumeral ligament. They blend in with the joint capsule. Something interesting to note, we really don't have a whole lot of ligamentous support in the armpit. So these ligaments tend to focus on the anterior, superior, and posterior, but we really don't have ligaments on the bottom here. This is one reason why the inferior shoulder dislocation is pretty common, because we just don't have as much ligamentous support. So if a shoulder is going to dislocate, it commonly goes in the inferior direction. All right. What about the joint capsule? So we just may remind ourselves that we have a capsule of connective tissue. I likened it to thick saran wrap. We have a capsule of connective tissue surrounding the synovial joint, contains the fluid, gives some support, yada, yada, yada. It's my Seinfeld reference. But here's what I want to say about the joint capsule. So this was about the ligaments, correct? You just follow along in your notes. Let's see what I want to say, what's important about the joint capsule. So the glenohumeral joint capsule. Like every other joint capsule, this just encapsulates the joint, keeps the synovial fluid in. Technically, the joint capsule is right around the bones and the ligaments are a little outside of it. I want to remind, it's true of all joint capsules, but it becomes especially important here. This connective tissue, so it's made up of, if you really want to know, dense irregular connective tissue, but it's made up of pretty thick connective tissue. So it's made up of thick connective tissue. But what I want to point out is that the joint capsule here and everywhere, but particularly here, it is not elastic. That connective tissue that surrounds the joint and keeps the synovial fluid in, it is not elastic. That means that if we stretch it, it's not going to recoil. If we have a shoulder dislocation, if the head of the humerus pops out of the socket, it's going to stretch the joint capsule. But you see that joint capsule, it's not elastic. It might recoil a little bit, but it will always stay a little bit more stretched out. This is one of the big reasons why, if someone dislocates their glenohumeral joint, they're much more likely to have a second dislocation. Because that joint capsule, once it gets stretched, it's not elastic. As a matter of fact, do you know what percentage of people who had a shoulder dislocation, what percentage have another dislocation again, have a recurrence? 80%, folks. 80% of people who dislocate their shoulder will do it again. Not fun, right? Okay, moving on with the anatomy here. This is I think I mentioned this in the joint chapter, but I didn't have you know it. But here I am going to have you know at least what it is. Just took a sip of water there. So what is bursa? Bursae is plural. Bursa is singular. So what is a bursa? It is a fluid-filled sac. It is usually found in areas where there's friction between bones. If I could spell. Located in areas with a lot of friction between bones. Fluid-filled sac, purposely put there by the body because we have a potential area of friction. So what is its function? It functions to reduce friction. Cool. So let me give you one example. You're not going to have to know the specific bursae around the glenohumeral joint. You can see I've listed them. There's a subscapular bursa, subcoracoid bursa, and subacromial bursa. You don't need to know the individual names. But the one I'm going to point out just to help, hopefully, to help you understand what's going on is the subacromial bursa. The name subacromial should give us an idea that it's underneath the acromion. Let's remind ourselves of the anatomy, the acromion process. This. So the blue things here, these blue things are the subacromial bursa. It's a fluid-filled sac. It's hard to put into words. If I had to try and give you an example of what it really looks like, it's kind of like a jellyfish from the ocean, but a more contained jellyfish. So it's kind of like this gelatinous thing filled with fluid, and it gives cushioning. So here underneath the acromion, we just talked about that gliding and angular movement, that once we abduct at the glenohumeral joint, at a certain point, the head of the humerus is going to hit up against the acromion process. So here we have an area of friction between two bones. The body doesn't want friction between two bones. So in this case, it puts a little padding, but a really loose, fluid-filled padding called the bursa. Maybe you've heard of bursitis, inflammation of the bursa. These should have a little bit of fluid in them, but we don't want them to fill with too much fluid. That would mean that there's some kind of overuse happening, and the body has filled it with more fluid as a way to protect. But the fact that it fills with more fluid makes it larger and can be quite irritating and cause inflammation. All right, so just know what it is. Fluid-filled sac found in areas where there's bone-on-bone friction. Its job is to reduce friction. The last piece of anatomy I want to introduce with the glenohumeral joint is the labrum. The labrum is an added piece of cartilage. Added piece of cartilage. We already know, you see how it all comes together, folks? We already know that lining the end of every long bone is hyaline or articular cartilage. That was part of what I asked you to know about the synovial joints. In every synovial joint, like a little glove, like a thin glove, there's a layer of hyaline cartilage. But this is an added piece of cartilage above and beyond that hyaline cartilage. The other example where we see an added piece of cartilage is the menisci in the knee. So if that gives you an idea. We still have the hyaline cartilage lining the ends of the long bones, but here we have an additional piece called the labrum. I will tell you a little story. Hopefully it'll keep you awake. I think I told you that my background is athletic training, and one of the gentlemen that I have met in my career, his name is TK, that's what he goes by. Years ago, he was an athletic trainer at West Point. And, you know, the plebes, the first years, he would have time in the training room, and they would come in. And this one gentleman, he said, the one plebe came in and said, "Sir, I hurt my labia." And TK said, "Excuse me?" And the plebe, the guy, points to his shoulder. He's like, "I hurt my labia." Well, what he meant to say was labrum. He believed that he had hurt the labrum of his shoulder, but he had incorrectly stated the labia, which is, of course, a part of the external female genitalia. So, you know, this is why spelling is important, folks. All right. So if we're looking at the picture on your left here, let me go back to yellow. This labrum here, so it's trying to show you this added piece of cartilage right in the joint surface. I want to remind you, if I go back to the blue color here, this here is showing you the hyaline cartilage, like a glove. That's still there, right? That hyaline cartilage is still there. What we're talking about is an added piece of cartilage called the labrum. If we look on the right picture, this is a view looking straight in this way. But I want to point out the labrum. It's this white area. And it's kind of hard to visualize, but the best way that I can think about it, do I have a picture? Yes. The best way that I can think about it, it's a ring, kind of like this rubber ring in a mason jar, that rubber lip. So if we're talking about the glenoid, that socket, this labrum is a more or less circular piece of cartilage, and it kind of sits in the head of the humerus like a ring around it. And the reason I'm using this example, not only does the labrum help to cushion, of course, anytime we add more cartilage, it's a cushioning effect. We could also use the words shock absorption, right? But the reason I'm using this example is because it deepens the joint. You know, it's not a very deep socket, the glenoid, so it's actually helped to have this cartilage that's kind of like a rubber lip. And I don't want to say it forms a vacuum, but it adds a little bit kind of like a vacuum seal. And I'm just going to write kind of, because it's not a true vacuum seal. But you know, if you have that mason jar, when you close the lid, the presence of that rubber lip, it makes the closure a little bit more suctioned. So the shoulder benefits from this. It's mostly about shock absorption, and it forms a circular ring, kind of like the ring around a mason jar. But it also has a little bit of that vacuum effect. It suctions just a little bit, and that just helps with stability. But please, folks, let's please call it the labrum, not the labia. All right, I've already mentioned an easy comparison is between the shoulder and the hip. So we're looking at the glenohumeral joint on the bottom. Remember, the glenohumeral joint is formed between the glenoid cavity of the scapula and the head of the humerus. Look at that shallow socket. On the other hand, when we get to the hip, look at how much deeper that socket is in the hip. Much different. On the bottom right is another great picture of the subacromial bursa, fluid-filled sac. We get a good look at some of the glenohumeral ligaments, okay? And then, actually, this is a good picture of the coracohumeral ligament. You didn't need to know that, but it just shows you that it goes between the coracoid process and the head of the humerus. All right. In this video, I will get through all these joints. And then when we meet in person, and in lab, we're gonna review the muscles around the shoulder complex. But when we meet in lecture, we'll fill in the rest of the stuff about the shoulder, the kinetics, all the other good stuff. So here's our second joint in and around the shoulder, the scapulothoracic joint. It is formed by the scapula and the ribs. The ribs that are part of the thoracic region. I mean, this is really an interesting joint. We don't really think of it as a joint, but just take a minute. I mean, we know the scapula, right? It just kind of is affixed to our rib cage. It's kind of weird, isn't it? But being that it's bone on bone, anytime we have two or more bones that come together, it's a joint. It is a joint, and there is some motion. It's kind of rad. So, what type of joint? Well, it's not a true synovial joint. So, honestly, we don't really have a definition for it. So the type of joint is undefined. It's not a synovial, it's not a cartilaginous because there's not cartilage in between, and it's not a fibrous joint because there is some motion. So we really don't have a category to fit it in. What motions are allowed at the scapulothoracic joint? I think we should already know this. Scapular elevation, depression, protraction, and retraction. They're listed there. This is an example of we have joint-specific names. Elevation, depression, protraction, retraction. These are the joint names for what happened. These are the names for what happens at the scapulothoracic joint. So why on earth do we have this joint? Functions. Well, honestly, one function is to help connect the arm to the body. I mean, keep it simple, folks. Remember, what does the head of the humerus fit into? The glenoid cavity of the scapula. So without the scapula, the humerus wouldn't have a socket to fit into. Think about it. Without the scapula, it just wouldn't make sense to just have the head of the humerus attached to the rib cage. So one function of the scapula, as it sits against the thoracic rib cage, is it helps connect the arm to the body. It does add a little bit of stability. Remember, we don't really have a whole lot of stability in and around the shoulder anyway, but this adds a little bit. Not great though still. But I'm going to star the two big functions. Helps connect the arm to the body, and then it allows for greater glenohumeral joint motion. We already talked about the example. As we abduct the humerus at the glenohumeral joint, it's going to hit up against the acromion process, so we have to glide the head of the humerus down as it fits into the glenoid cavity. But it's also more than that. We're going to talk in a minute about scapulothoracic rhythm. But this arrangement allows us to get even more glenohumeral joint motion. Okay. Let's talk about that scapulothoracic rhythm. We're going to assess this in lab. You can read from your notes. Pattern of scapular rotation that accompanies glenohumeral abduction. We'll do this in lab because it's always easier when we can look at it in person, right? But let me just give you the basics, okay? Let's look at this picture on the right. This gentleman is abducting at the glenohumeral joint. He's got a wicked tan line. Look at that tan line. Whew. Looks like me from my cycling jersey over the summer. Cray, cray. So as we abduct, we know that there's that gliding motion of the head of the humerus down in the glenoid, but there's also more. So as we abduct, you know what also has to happen? The scapula rotates outward. As we abduct at the glenohumeral joint, the scapula also rotates outward. As we abduct at the glenohumeral joint, the scapula also rotates outward. And what's the ratio? Usually it's termed 2-to-1. For every 2 degrees of glenohumeral abduction, there's 1 degree of scapulothoracic rotation, 2 to 1. For every 2 degrees of glenohumeral abduction, there's 1 degree of scapulothoracic rotation. It's written right in your notes. Letter B, after 30 degrees of glenohumeral abduction, the scapula rotates outward 1 degree for every 2 degrees of glenohumeral motion. We're going to see this in the lab. There, of course, could be abnormal rhythms, so we're going to look at each other in the lab and see if it looks like it's about a 2-to-1 ratio. Some people might have some adhesions in the scapulothoracic joint that might limit scapulothoracic rotation. But really important. If you remember at the very beginning, I was talking about the fact that the glenohumeral joint rarely moves on its own. So here's an example of the glenohumeral joint abducting, but it's also going to involve scapulothoracic movement. We're also going to look in lab. There's also something called scapular winging. So the scapulothoracic rhythm was best looked at this picture, okay? But what if we wanted to look at scapular winging? Sometimes the scapula kind of wings outward more. You see this picture on the left? It almost looks like the scapula's popped out towards us. It shouldn't look like that, right? It should look more like what we see on the right picture. We can still probably make out the border of the scapula, but it's not popped out. So what we see on the left and what the red arrow and my yellow arrow are pointing to is scapular winging, when the scapula actually kind of pops out. We're going to be looking for that also in lab. There are no ligaments supporting this joint. It's more or less the scapula sitting on the rib cage. It's pretty cool. And we don't really think about it that often, but it's really important. All right, let's finish these last 3 joints, and then we'll be done with this video. Our third joint in and around the shoulder complex is the acromioclavicular joint. This is formed between the acromion process of the scapula and the distal end of the clavicle. Here's the acromion process of the scapula. Here is the end of the clavicle. We're going to be palpating these in lab to really hone in on your anatomical skills. But folks, this is what it says it is, acromioclavicular, joint between the acromion process of the scapula and the end of the clavicle. So really, it's this joint right here, AC joint. This is a synovial joint. It's technically, okay, so it is a synovial joint. But it's technically an irregular synovial joint. So we're not going to be more specific than that. It doesn't fit into any of the nice categories we already described. Hinge, ball and socket, plane, gliding, condyloid. It doesn't fit into any of those. So we're just going to simplify it and say it's an irregular synovial joint. But since it is a synovial joint, it does have a joint capsule. It does have supporting ligaments. What motions are allowed? As you can see on your notes, gliding. The primary thing we're looking at here is gliding. There's some rotation, but it's more about gliding. According to the textbook, it says that there's about 20 to 30 degrees possible of gliding and rotation, which is actually more than I thought. So it's not insignificant, right? So there's a reasonable amount of gliding. Maybe I'll even add moderate amount of gliding. What is the function of this? The functions would be, what would the functions be? Connect the bones, connect the clavicle with the scapula, but also assist with other shoulder motions. Particularly the glenohumeral joint. So a little bit of gliding at the AC joint can actually create more motion at the glenohumeral joint. A little bit of gliding here can create more motion at the glenohumeral joint. A little bit of gliding here can assist in motion at the glenohumeral joint. By the way, have you ever wondered why we even have a clavicle? It's kind of a weird bone because it's not very big and strong. Why do we have a clavicle? Clavicle? Question mark. Isn't this one of these existential questions? Why do we have a clavicle? If you want to know about the Latin root of the word, am I boring you yet? The Latin root, it means little key. But seriously, in more American human English terms, it obviously forms as it helps to form connections between bones. But one function of this is it acts as a lever arm. You know I was going to bring this stuff in again, didn't you? Whether you like it or not. Acts as, let me see if I can spell correctly here. Bear with me. Acts as a lever arm to distribute forces. It might not seem like it can do much of that, but the more that we can distribute forces from the glenohumeral joint, the better. Because remember, the other end of the clavicle goes to the sternum, which is a bigger, more stronger bone. So it does act to distribute some forces. Okay, let's talk about the primary ligament. Well, you know what, folks? The primary ligament is the acromioclavicular ligament. There is a superior and inferior band. You don't need to know that. We're just going to keep it simple. What's the ligament? The acromioclavicular ligament. It literally runs right between the two bones. So imagine a joint capsule around, right? But there's a ligament over top the joint capsule connecting the bones, acromioclavicular ligament. The AC ligament. You know what? I'm sure you've heard of a separated shoulder. This is the ligament injured in a separated shoulder. So it's fairly commonly injured. You don't need to know the separate bands, just know the ligament itself. It goes between the bones, acromion process of the scapula, end of the clavicle. Let me go ahead for 1 minute. We're going to see later. Hold on here. All right. I don't want to make us dizzy by going through all here. Whew. There's something that I'm going to bring up later called foosh, fall on outstretched hand. You know, if you fall, so you fall off a ladder, what's the common reflexive way, what what do you do reflexively? You put your arm out to brace, don't you? So a lot of times when we fall, we purposely put our arm out. But it's not usually our wrist or elbow or even glenohumeral joint that is injured in that. A lot of times, if we have a mechanism where we fall on an outstretched hand, the force from that fall travels up the arm, and it's going to, usually the weakest point will fracture first. So fall on outstretched hand. Imagine you're falling off a ladder. You put your arm out to brace you. Your arm touches the ground, and the force from that goes up your kinetic chain. It goes up your hand, wrist, elbow, glenohumeral joint. But these are all stronger. A lot of times, oh, there's my cat coming to say hi. Hi, Kima. Did you bring me a toy? Thank you. A lot of times, the weakest part is the acromioclavicular joint. So that force travels all the way up here, and the first thing to be injured is the AC joint because it's the weakest part of the kinetic chain. There's also a coracoacromial ligament, but you don't need to know that. So you can cross off coracoacromial ligament. You can cross off coracoacromial ligament. 2 more joints to go, and then we'll finish this video. Our 4th joint is the coracoclavicular. These are smaller, folks, right? Coracoclavicular, joint formed by the end of the clavicle and the coracoid process of the scapula. Before, we had talked about the acromioclavicular ligament. That was actually the most distal or lateral part. But not only does that clavicle articulate with the acromion process, it also articulates with the coracoid process. We're going to palpate this in lab. This is a process that juts out, kind of juts anteriorly. This is also an undefinable joint. It's not even a true synovial joint, so we're just going to classify it as undefined joint type. Very little motion here, very little. I'm not even going to say gliding. Very little motion. We don't expect to see much motion here. There are ligaments, though. So I'd like you to review the coracoclavicular ligaments. Well, check it out. They go between the coracoid process of the scapula and the clavicle. Technically, if you wanted to know, it's a combination of 2 ligaments, the trapezoid and the conoid ligaments. You don't have to know what each band is named. Just know that we have 2 ligaments. They just connect the 2 bones. There's 1 band and a second band. Just know them together. Don't want a lot of motion here. The function of this is just more about connecting the bones. This function is not as much about motion. This function is more about connecting the bones. Last joint of this video, sternoclavicular joint. Sternoclavicular joint. Well, as always, folks, it's named for the bones they connect. Joint between the sternum. This is the top of the sternum. Joint between the sternum. And here, I'll put the clavicle in a different color. I'll put the sternum in red and the clavicle in blue. Joint between the sternum and the clavicle. Let me circle that joint in yellow. Oop. Boom. We have 2 of them. Boom. We have 2 clavicles. They come and meet each end of the sternum. Joint between the clavicle and the sternum. This is also an undefined joint. Undefined joint type. Similar to the previous coracoclavicular joint. Oh, wait a minute. I'm reading the wrong one. Holy cow. Bear with me, folks. Joint between the clavicle and the sternum. If we are going to be specific, it is the manubrium of the sternum. The manubrium of the sternum is that top region. I apologize for that mistake. I was reading the wrong part of my notes. This is a modified ball and socket joint. Modified ball and socket. Which means that one end is more like a ball, one end is more like a socket. Let's examine that. Well, the clavicle is more like the ball, and the manubrium of the sternum is more like the socket. So it's a mini little ball and socket. What are the primary motions? Rotation. And when I say rotation, you can see it on your notes there. Major axis of rotation for movements of the clavicle and scapula. So it really allows the clavicle, to kind of move up and down. Rotation. Most specifically of clavicle. Remember, all these joints work together, but it really is the foundation where the one end of the clavicle can be secure. This end of the clavicle is much more stable. The lateral end of the clavicle is not as stable. There are some pretty interesting supporting structures here. Is there a better picture? Let's see. Yeah. Let's see if it shows it here. Yeah. So in this joint, there is a supporting structure called a fibrocartilaginous joint disc. It's similar to an added piece of cartilage. It's just not as big as the labrum in the shoulder or the meniscus in the knee. But it is indeed an added disc of cartilage. So we can see the fibrocartilaginous joint disc. Here they call it articular disc. In between the bones, we just have this added disc of cartilage. As the name suggests, it is made up of fibrocartilage. What is the function? Shock absorption. And a better fit for the joint. And it's kind of like what I was talking about with the labrum, how it has that almost vacuum-like seal. It just makes the joint a better fit. And again, it's not a true vacuum, but a vacuum-like seal. It really helps to just better bind those ends of the bones together. All right, there are some ligaments. Even if you just look at this picture, we can see a lot of ligaments, right? A lot of ligaments. Let's identify them. Sternoclavicular, costoclavicular, intraclavicular. Now, you might think that this is intimidating, but the beautiful thing is, in each of the names, it tells you what bones it connects. The sternoclavicular goes between the sternum and the clavicle. These are the primary ones. Primary. Strongest and primary. Costoclavicular, between the clavicle and the first rib. Costo means rib. And then the interclavicular runs between the two clavicles. That bony connection, believe it or not, is not quite so strong, so it really relies on ligaments. All right, we're going to end there. In lab, we're going to focus on the muscles, and then in lecture, we will finish this chapter. Study, 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 review your anatomy. I will see you soon.